Malaria is an important essay question. It is also a very important public health problem. We're going to look at it right now. In this video, we will be looking at the introduction, the problem statement, the agent factors, host factors, and environmental factors, which comes under the epidemiology. And we will be looking at the prevention and control, treatment of malaria, measurement of malaria, the diagnosis, clinical features, and so on. So let us dive right into it. Malaria, as we all know, is a mosquito-borne disease. It is caused by malarial parasites. The problem statement globally, 97 countries or union territories had ongoing malaria transmission. In India, March 2013 to April 2014, the total cases were 0.8 million and deaths were 379 million. The primary vectors are, the primary vector, Anopheles mosquito, which is many species. Some of the names are very hard to pronounce, but yeah. Anopheles culcifacius, this is the main vector in rural and peri-urban areas. Anopheles stephensi, which is the main vector in urban and industrial areas. Anopheles fluviatilis, which is the main vector in hilly areas, forest and forest fringes. Anopheles minimus, which is a vector in foothills of northeastern states. Anopheles dirus, which is a forest vector, it is in northeastern states. And Anopheles epiroticus, which is a vector restricted to Andaman and Nicobar Islands. Next, we're going on to the epidemiology. So in that we have the agent factors, host factors, and the environmental factors. So in agent factors, the agent is malarial parasites. So we know malaria in humans is caused by 4 species of malarial parasite. So we have Plasmodium vivax, which is the widest geographical distribution, and almost 50% of malaria in India is by Plasmodium vivax. Next is Plasmodium falciparum. It causes the deadliest form of malaria, and it causes malignant malaria. Almost all malaria deaths are due to this species, Plasmodium falciparum. Next is Plasmodium malariae. So this is a restricted distribution and it accounts for less than 1% of all the malaria cases in India. Then we have the Plasmodium ovale, which is a very rare parasite, and it is mostly confined to the tropical Africa and Vietnam. Now, what is a reservoir of infection? Except chimpanzees in tropical Africa, there is no other animal reservoir. Human reservoir is one who harbors the sexual forms. So the sexual forms, if a human reservoir harbors it, then that person will become the reservoir of infection. What is the period of communicability? That is a period in which the person can give the disease to another person. So malaria is communicable as long as viable, mature gametocytes are circulating in the blood in sufficient quantities to infect the mosquitoes. An appearance of gametocytes in blood after the appearance of asexual parasites. So in vivax, the gametocytes will appear 4 to 5 days later after the appearance of asexual parasites, and in falciparum, it will appear 10 to 12 days later. Next, let us look at the host factors. So the host factors we have age. So age, malaria affects all ages, and newborn infants are quite resistant to infection with Plasmodium falciparum because they have high HbF concentration. The sex, males predilection in females, and it is largely due to the greater exposure and outdoor life they have. Okay, race. No racial difference is there. There is no racial difference. However, those with AS hemoglobin have milder Plasmodium falciparum illness than those with AA hemoglobin. AS hemoglobin means the one with sickle cell trait. So that has milder Plasmodium falciparum illness than those with normal hemoglobin. And those with Duffy negative RBCs are resistant to vivax infection. Pregnancy increases the risk of malaria. Socioeconomic status, lower socioeconomic status is more affected than higher socioeconomic status. Human habits, by sleeping outdoors or not using personal protective measures. Immunity is acquired only following repeated exposure to malaria over several years. And active immunity is species specific, that is, cross immunity against other species is not there. So if you get infected with Plasmodium vivax species, you do not get resistance against Plasmodium falciparum species. That is what is meant by cross immunity against other species is not available. Now, occupation. Malaria is predominantly a rural disease and is related to agricultural practices. Population mobility, migration, emigration, travel are associated with import or export of malaria. Housing, ill-ventilated, ill-lighted houses are an ideal indoor resting places for mosquitoes. That is all about our host factors. Environment factors. Season. In India, maximum prevalence is from July to November. The temperature, optimum temperature is 20 to 30 degrees Celsius for parasite development. Because above 30 degrees Celsius, it is lethal to the parasite. And parasite stops undergoing development below 16 degrees Celsius. The humidity, relative humidity greater than equal to 60% is required. So in rainy seasons, you know what happens. Rainfall increases the humidity, providing better breeding opportunities. Altitude, Anopheles are not found greater than 2000 to 2500. You do not find Anopheles mosquito. Man-made malaria is a term used to refer to malaria due to human undertakings such as irrigation channels, pits, pools, engineering projects, etc. Next, we are going to look at the transmission. So, transmission is vector transmission, direct transmission, or congenital malaria, which is rare. Now, vector transmission is by bite of certain female Anopheles species. Female Anopheles species. Note that. Now, mosquito is not infective unless the sporozoites are present in the salivary glands. This is important. Mosquito is not infective unless there is sporozoites in the salivary gland. Now, direct transmission is by IM or IV injections, drug addicts do it, and by transfusion of infected blood. And then, as we said, congenital malaria. Now, the incubation period varies for different species. Plasmodium falciparum is usual of 12 days. Vivax malaria is usual of 14 days. Cotton malaria 28 days. And ovale malaria 17 days. Plasmodium ovale 17 days incubation period. The ranges you can remember if you want or not. Clinical features. So in clinical features there are 3 stages importantly. So we have the cold stage, hot stage and the sweating stage. So the cold stage, initially the duration it is 15 to 16 minutes and it is characterized by severe headache, nausea and chills, which is followed by rigors within 1 hour. 1 hour you get rigors. Now the temperature rises to 39 to 41 degrees Celsius. So in the early part the skin will feel cold and later on the skin will feel hot. The parasites will be demonstrable in the blood and the pulse is rapid, may be weak. Alright, now in hot stage what happens? So as the name suggests, the patient feels very hot and the patient will cast off the clothes. The headache is intense but nausea will diminish and the duration of this stage is 2 to 6 hours. The pulse here is not weak, it is full and the respiration is rapid. Now what happens in the sweating stage? Again in the name, there is profuse sweating, the patient sweats profusely and the fever diminishes. So you know, because of profuse sweating, the temperature returns to normal, the skin is cool and moist and the pulse is slower and the patient often falls asleep. The duration of this stage is 2 to 4 hours. Now how do we diagnose? So mainly we have microscopy, so thin film and thick film we take. Thin film is to identify the species and thick film to detect the parasites. So the species, whether it is Plasmodium vivax or falciparum or ovale or malaria, you can find that out with the thin film and you can identify the parasites with the thick film. Next is the serological test. Serology we do, and that is the malarial fluorescent antibody test, which becomes positive greater than equal to 2 weeks after the primary infection, and this does not indicate current infection. Next, what we have is rapid diagnostic test, which is also very important. So this is based on detecting of circulating parasite antigens by dipstick method. In measurement of malaria, we have the pre-eradication era, the eradication era, and the vector indices. So in the pre-eradication era, we used spleen rate, average enlarged spleen, and so on. So what is spleen rate? The percentage of 2 to 10-year-old children showing splenic enlargement. What is average enlarged spleen? Average size of enlarged spleen. Parasite rate is percentage of 2 to 10-year-old children showing malarial parasites in the blood films. So it is based upon 2 to 10-year-old. Spleen rate, percentage of 2 to 10-year-old children showing splenic enlargement. Parasite rate is percentage of 2 to 10-year-old children showing malarial parasites in the blood films. Now parasite density index is the next, and then infant parasite rate. So percentage of infants showing malarial parasites in blood films. Proportional case rate is the number of cases diagnosed as clinical malaria by the total number of persons attending the hospital into 100. In the eradication era, now these are important. We have the annual parasite index. Okay, so annual parasite index. So that is the confirmed cases during 1 year. Annual, right? So there is a confirmed cases during 1 year by the population under surveillance into 1000. Next is annual blood examination rate. So that is the number of slides examined by population into 100. Next is annual falciparum index. So that is the confirmed Plasmodium falciparum cases during 1 year. Annual falciparum index. So confirmed Plasmodium cases by the population under surveillance again into 1000. So annual blood examination rate was in 100. Both these into 1000. Now slide positivity rate, slides positive for malarial parasite by total number of slides examined into 100%. Slide falciparum rate is the slides positive for Plasmodium falciparum by total number of slides examined into 100. The vector indices. So in the vector indices we have the human blood index. These are relatively not that important, but let's just look at it. This is in the vector indices. You have all these. The human blood index, we have the sporozoite rate, we have the mosquito density, we have the man biting rate or the biting density, and we have the inoculation rate. Take a look at this. Just go through it quickly, and next we'll move on to the prevention and the control. So strategic plan of 2012 to 2017 gives the strategies for prevention and control of malaria and its transmission. So we have these, and you have to write under these headings. It will fetch you a lot of marks. So surveillance and case management. So you have case detection, passive and active case detection, early diagnosis and complete treatment. So this is just an overview. I want you to go to your textbook and read these topics after you watch this video, and that will make your job really easy. And you can just come back to it and visit this video anytime. Okay, so don't just rely on this. If it is last minute preparation, okay, fine, but still, if it's revision, it's good. But then if you are learning it for the first time, I highly recommend you go and read your textbook after you read and go through this thoroughly. So in surveillance and case management, we have case detection, early diagnosis and complete treatment, and sentinel surveillance. In integrated vector management, we know we have indoor residual sprays. We use insecticide treated bed nets and long lasting insecticidal nets. We have anti-larval measures including source. Okay, next is epidemic preparedness, and we have to respond early response. Then we have supportive intervention. So what do? We build the capacity building, behavior change, communication, intersectorial collaboration, that is collaboration between the different sectors, the different ministries. All right, and we have the monitoring and evaluation. We have research, operational research, and applied field research. Next, we move on to another important subtopic. Okay, this can be asked as a short essay also. It's a vector control strategies. So we have anti-adult measures. You can write this under integrated vector management, if that is the question. So anti-adult measures and anti-larval measures. Okay, so anti-adult measures, we have the residual spraying with DDT, malathion, phenytothion. Space sprays can be used, that is application of insecticides in the form of spray or mist. You can apply insecticides, and this will rapidly reduce the vector population. Okay, then you can write this as a separate heading. Okay, you need not write this under anti-adult measures. You can write it separately. So that is the use of personal protection, that is the use of repellents, protective clothing. You can use mosquito bed nets, screening of houses, etc.
Then we have anti-larval measures. So anti-larval measures, we use larvicides, so that is mosquito larvicidal oil, fuel oils and Temefos. Then source reduction, so reduce the breeding areas. So you do environmental modification, just do not allow water to collect, do not allow long standing of water, so you reduce the breeding areas. And integrated control, that is the approach to reduce the dependence on residual insecticides and to prevent the insecticide resistance. So this is all about malaria.
Do subscribe and share with all of your friends, because a lot of effort goes into these videos. Thank you.